I'll try not to be too redundant. Jay gave a great talk yesterday in relationship to penile curvature and in the context of IPP, so I'll try not to get too into that, but we are going to talk about Peyronie's a little bit. Okay, these are my disclosures. So you cannot have a Peyronie's talk without having some version of this slide. And so Peyronie's disease is protean in the way it manifests. And of course, so we have our northern ones at the top and our left-leaning and right-leaning political penises, our neighbors to the south. And I always like to put in the middle the dreaded Argentinian duck corkscrew penis, which you definitely do not want to encounter in your practice. So I'm going to only focus on surgical treatment for this talk. There's a whole medical side of things, but that's another subject. So when we talk about surgical treatments, we kind of generally lump them into three categories. There's the shortening procedures, and I'm going to put that in quotes for a reason I'll get to later, lengthening procedures, and then a prosthesis, which are without some sort of adjunct maneuvers, as Jay talked about at length yesterday. So graft materials, there's lots of them out there. In my life, I've used saphenous vein, I've used buccal mucosa, I used tutoplast a lot. We heard about Tacoseal, which I do prefer now, much easier to deal with, although I still use tutoplast for a lot of things. But there's a lot out there, and nothing is perfect. Everything has its problems. So if someone's deciding whether to do one of these shortening or lengthening, it depends how you phrase it, right? If you say to a given guy, would you like your penis shortened or lengthened, you're going to get very few people who are interested in a shortening procedure. But that's maybe not the best way to look at it. So when we talk about shortening and lengthening procedures, are we really comparing apples to apples, or whether we're not so much? So in the ideal world, a patch kind of procedure will lengthen the penis and a plication will shorten it. Neither will affect erectile rigidity, and they take care of all deformities, and that'd be great. Then you can just make that decision. But the world in which we live, it's not quite the same. We have to think about whether there are these shortening or lengthening changes, how these different procedures affect erectile rigidity, at least de novo erectile problems, the satisfaction for these procedures, and are they the same, and other complications that have, and can they be used in all scenarios? And I'm not going to go through all scenarios for sure, but we'll go through some. So of the shortening procedures, which are some variation of something you do to the tunica to plicate it, and that can be incisional or non-incisional. And the classic indications for this is if you have a deformity that is curvature only, because of course a tunical plication can't correct a non-curvature deformity. You don't have profound ED, and the penile length is adequate, whatever that means, and that certainly depends on the patient. Whereas lengthening, the classic indications are some sort of severe curvature, as defined a bit arbitrarily by different people, excellent erectile function, a shorter penis, again, however you define that, and curvatures that deformities that are non-curvature, meaning they cannot be corrected by plication alone. And what are some different clinical scenarios? You can have uncircumcised phallus. You can have ventral curvature, especially in core D. Multiplanar curvatures, very severe curvatures, prosthetic surgery and the adjuncts that go with that, and non-curvature deformities. So this is just a picture of a multiplanar guy who's actually not. Oh gosh, he was uncircumcised, and you can of course not see that here because I've stretched down the skin, but you want to think, well, what kind of procedure do I want to do? In this case, we used a ventral fait so we could preserve the foreskin, and this is our incision of choice for the most part to avoid the inevitable postoperative edema from the uncircumcised. This is someone who has a severe ventral curvature, and so this was done as a dorsal penile inversion technique. You can see the deep dorsal vein. We left it alone in this case. Often we take it out, and we've moved the nerves off to the side, so we don't have problems with that. And this is what that person looks like when they're straightened, and again, they get to keep their foreskin. This one is, you see from a couple different angles. This is multiplanar. So, you think, well, can this be, what's the best way to address this? Well, now that we've, in this case, a bit of a degloving, which I don't generally do anymore, but as long as you can set up the sutures maybe a little asymmetrically, you can still achieve straightness with these multiplanars. Now, is there a limit to the angulation correction? We can see this poor fellow on the left. This is a severe curvature, no matter how you looked at it. I think this one was 120. So that's severe. But this patient does not want any risk of ED. So he gets a plication. We still make him straight. Is he going to be long and straight? No. But if you talk to the patient, decide what their priorities are and what they're willing to put up with, this may be a reasonable option. So what about something like this? We can see every urologist's favorite beer, Peyronie's. And this is what this fellow looks like. He looks like this Peyronie's bottle. Is this a guy who's good for plication? Probably not. And this fellow on the right, you can see he's degloved, but he's got a pretty significant hourglass deformity that's pretty obvious in this picture. Now the neurovascular bundle has been taken off to the side. Is that good for plication? Maybe. So what about in the context of IPP? I don't want to belabor this because Jay gave a great talk on this yesterday, but one option is to do nothing, and there tends to be some straightening over time depending on the plaque characteristics. You could do modeling. You could do these shortening or lengthening procedures. So this is just an example of a guy that I had. Here what he looked like preoperatively and put in the IPP, and you can see he's actually pretty curved still on this lower picture off to the left. So then modeled a couple of times, and maybe we just didn't do it the 5 or 6 or 10 times that was suggested. He only had 2, but he still doesn't look so straight. So in this case, I did plication afterwards, sort of removed the implant temporarily, put in the plication sutures, and then put the strings back on tension to pull the implant back in, and now he's nice and straight with plication. Modeling. We talked about this a bit yesterday. This was introduced quite a long time ago before Dr. Wilson, but Dr. Wilson was really the one who kind of brought this to the attention of people. And it is the procedure that is used the most. It is often used in straightening procedure as the first move, and often it works. Are there any problems with this? Yes, I would say there's lots of problems, and it has to do, I think, with plaque characteristics. So we had published some time ago just a small series, 7 patients who just had modeling, and what they looked like after the case, and half of them had thinning of the tunica, half of them had extrusion through the tunica, and one had extrusion all the way through the skin. And what had happened in these patients is that the plaque, which was very dense and ossified, wasn't really able to be modeled. So the penis stayed facing the same direction, whereas the implant itself straightened out over time, thinned out the tunica, and eventually went through it. Oops, wrong button. Curvature of the time IP. This is from a little bit different series than Jay had discussed yesterday. This was from a large registry study that had been sponsored by AMS at the time, looking at men who had curvature after IPP and what they required, and it turns out that most of them got modeling, and modeling was the one done on the least severe curvature and the most likely to fail, going on frequently to secondary and even tertiary procedures for this. Additionally, I think it's important to remember that many men who do not have clinical Peyronie's are found to have curvature once you do the implant, and that's for a variety of reasons. A big one is that a lot of these men haven't seen their erection in a long time, and they have no idea what has happened to them over the years that they spent without an erection. And so it is important to keep in mind the importance, at least, of doing an artificial erection at the beginning of the case, but maybe even before the case, so that the man is aware of what their penis looks like. And some of these men will require correction, so I would be ready, for those of you who put in implants, to be ready to address these issues should you find them intraoperatively, because they may be a surprise. How should we assess deformity? Well, one thing we probably don't want to do, unfortunately in this case, is listen to patients. Patients will often be wrong about this. So this was a study that's very often talked about in these various presentations in this matter. But if you ask patients what their erection looks like in terms of the curvature, and then you objectively measure it in one way or another, they tend to be off. They tend to overestimate it about half the time. Maybe they're trying to over-exaggerate to talk about the severity for the surgeon, or they're just very bothered, or they underestimate it, especially those with erectile dysfunction, where they don't know what a rigid erection looks like. And so as the erection becomes more rigid, the curvature becomes greater. Incision choices, circumcision, that's kind of the classic. I don't love that from a healing point of view. Ventral RFA, dorsal penile inversion, penoscrotal, these are all reasonable incisions that one can make in these cases, and each different for different people. The length issue, this is going to come up a lot, and I think it is important to remember when you're counseling patients that when you have a patient with Peyronie disease or Core D, the length really is determined by the concave side. And so when you do a stretched penile length, you are measuring the short side. And so in a way, plication doesn't shorten the penis, it shortens the long side of the penis and just makes it match. I would say this is one of the very important things is always do a measurement of the penis preoperatively whenever you're doing any kind of penile surgery, because first of all, you want to know for yourself, and second of all, patients will always disagree with you. Oh, doc, I used to be this big, and you say, well, your memory's terrible, but you probably weren't, and even if you were, it doesn't matter because you are what you are. We're operating on the penis you have now, not the one that you recall from 20 years ago. Keep hitting the wrong button there. So penile shortening, does it happen? Well, yes, sort of. It depends on who you ask and how you ask it. So these are some series where patients feel that they had shortening after a 16 dot sort of a Lou procedure in this first one or a Nesbitt procedure in the second. But these are subjective bits of data. So these are patients feeling that they've had shortening. You see, not all of them, but a lot of them feel they had shortening, and quite a lot of them felt that it was so short that it actually prohibited coitus. These are Core D patients in the second one. 100% said they had shortening with a Nesbitt. Most said they had it in a multiple plication kind of technique. And same thing, how much did they guess they lost? Well, 0, 2.5 centimeters. But these are patients' subjective views in the matter. But does this really translate to their measured loss? So these are patients getting a tunica plication, a little bit of an excisional one, Dr. Levine's group. And while most of them felt that they had shortening with a perception of about 1.5 centimeters, only about 20% actually had shortening, and it was a bit less than what they felt that they had. I won't belabor this because Jay had a very comprehensive graph of this, but I did want to show a couple slides that look at the plication techniques versus graft techniques and how people really see the complications. So you can see these are plication techniques. How many of them are straight? Most of them. How many of them got de novo ED? Very few, except for this one study by Savoca. Decreased sensation, a little bit all over the board. Now, if we compare this to grafting techniques, you can see the straightening is quite good, but de novo ED, these numbers are high, and decreased sensation a little, again, all over the board, but they're not low either. And so it is important for patients to understand that with a lengthening procedure, you may rob Peter to pay Paul in terms of erectile function. We, for example, will not do a grafting procedure on someone unless they not only agree to do all of their postoperative rehab as we ask them to, but that they are theoretically willing to have an implant down the road just in case they were to get profound ED. Another one, this is looking at the autologous grafts, and you can see, again, percent straightening, quite good, percent shortening, and then this is subjective, shockingly high for something that is touted to be a lengthening procedure. And then in the last column, you can see de novo ED, again, all over the board, but pretty high in the grand scheme of things, especially as compared to plication. So what about traction? This came up a little yesterday, but I think it's important to go into this a little bit because we really insist on patients doing traction both pre and post-operatively. So this is just looking at the TAP procedure, so that is a plication technique. And then on the right-hand side, these are patients getting plaque excision and grafting. And we are looking at this in terms of the measured length changes, right? So this is objective, not subjective. So if you do the TAP procedure with traction, there is a measurable length in the stretched penile length increase there. Whereas if they have loss with traction, that's very few. Now we go to the second column here and see that it is completely the opposite. If they do not do traction, they tend to have some length loss, and they do not have a lot of perceived length gain. Same with, so PEG, which is, again, this was supposedly the lengthening procedure. You can see that if they do traction, well, they do actually gain length, the vast majority of them, whereas without traction, half the patients do not actually have a gain here ultimately, or even a loss. So now switching to the patient perception, not the objective data, but the subjective data, you can see something very similar and maybe a little surprising. So those who had a plication technique, ostensibly a shortening procedure, about half of them felt they got length gain if they did their traction, and no change for the rest of them. Without traction, again, very opposite findings. Same with PEG, this lengthening procedure. If we look at the far right column, those who did not do traction, very few of them feel like they actually gained length, and the majority felt that they lost length with their lengthening procedure. So if we try to kind of put this together, and we say those who had traction in the first column didn't have traction and had traction in the second column with the excisional and grafting procedure versus those who did not have traction, big difference in terms of both the measurement and the perceived length for those who have traction, and quite the opposite for those who do not. So traction, I would do that. Comparison papers, there's not a lot of comparison papers out there. You can see the age of this one. I don't think there's anything more contemporary. Looking at the comparison of plication and patch, well, if you do try to make this comparison, unsurprisingly, those who have plication have palpable sutures. They generally have permanent sutures. The patches are likely to have loss of rigidity, about half of them, loss of sensation, at least temporarily, and inability to have intercourse. And usually that's because of size. But both reported shortening, and what I think is really the most important take home from this slide is that 80% of those who have plaque excision and grafting report shortening, as opposed to 70 who had plication. So the lengthening procedure is more likely to result in the perception of shortening. What predicts ED? Different studies say different things after a patch. There is a fair amount of de novo ED with grafting, and what Dr. Levine found in his study as non-predictors are some kind of counterintuitive things. The graft area didn't seem to matter, all these different risk factors for erectile dysfunction, but what did really predict ED was what the erections were like going into this. We talked briefly yesterday about the use of imaging, and to me, this is one of the few times when an ultrasound, I think, is really helpful. I'm not a big ultrasound fan in general, but for those who are going to have grafting techniques, I think it is important to get an idea of their vascular parameters, really to be able to counsel their patient on what their life will look like in the future. Are there any other useful predictors? Well, I think that ultrasound is helpful here. Those who have some evidence of leak and resistive index, that is helpful in knowing who is going to go on to an IPP and who is not. I think intuitively, not counterintuitively, those who have a larger graft, older age, baseline venous leak, they tend to go on to having an IPP. So conclusion, plicate when there may be some erectile dysfunction, but not enough to warrant a prosthesis. Circumcision is totally unacceptable unless you use one of these other surgical approaches, and the curvature is ventral, and I didn't get into that, but if you do grafting on ventral curvatures, the ED rate does go up. Patch when there's significant non-curvature deformities and the patient is willing to undergo postoperative traction and rehab, and always use traction for both subjective and objective success. Thank you very much.